Okay, welcome to this meeting of the Health and Adult Social Care Scrutiny Board, which is being live streamed. My name is Councillor Elaine Giles and I am the chair for this meeting. Please can all attendees mute their microphones unless they have been invited to speak. If anyone wishes to speak, please use the raise hand feature or send a message using the chat feature, and I will invite you in turn on your microphone at the appropriate time. When you are finished speaking, please remember to turn off your microphone. Firstly, all members of the board present, please introduce yourselves. Can I start with Councillor Jarvis? I'll come, Councillor Piper.
Yeah, Councillor Bob Piper, Vice Chair of this committee.
Councillor Jarvis. I'll come back to that one. Councillor Costigan.
Good evening, everybody. Councillor Costigan. I represent Wednesbury Northwood and I'm part of the panel. Thank you.
Councillor Carmichael.
Yeah, thank you, Chair. I'm Kerry Carmichael, Councillor in Blackheath. Thank you.
Councillor Jones.
Good afternoon, everyone. I'm Councillor Richard Jones and I represent Old Worley.
Councillor Sue Phillips. Councillor Phillips, can you introduce yourself? Your mic's on. Oh.
Sorry, I couldn't hear anybody speaking. Hello, my name's Councillor Phillips, Charlie McGraw Vale.
Thank you. Councillor Hartwell.
Hi, I'm Councillor Suzanne Hartwell, the Old Ward.
I'll go back to Councillor Jarvis. She must be having difficulty.
Evening.
Oh, Isaiah. Can you
I'm
introduce
Jarvis,
yourself?
Councillor for Great Bridge.
Okay. Now I'd like to get the officers of the, because we've got quite a few officers with me, and I'll get those to introduce themselves now. We'll start with Claire Blackburn.
Hi, I'm Claire Blackburn. I'm Senior Commissioning Manager within the Better Care Fund team at Sandwell.
Thank you. Mike Carr.
Hi, I'm Mike Carr. I'm the Group Director of Operations for Primary Care, Community and Therapy Services at Sandwell and West Birmingham Hospitals.
David Carruthers.
Hi, David Carruthers, Medical Director, Sandwell West Birmingham Hospital Trust. Good afternoon.
Good afternoon. Christine Guest.
Yeah, I'm Chris Guest. I'm Service Manager within Adult Social Care in Sandwell with a lead for commissioning and integration.
Dave Bradshaw.
Good evening, everyone. I'm Dave Bradshaw. I represent Healthwatch Sandwell.
Karen Ems.
Hi everyone, my name's Karen Ems and I'm Service Manager for Adult Social Care within the Council and lead on social work and therapy.
Marion Long.
Hi, I'm Marion Long. I'm Group Head of Nursing, work for Primary Care, Community and Therapies, which is part of Sandwell and West Birmingham Hospitals.
Neil Cox.
Hi, I'm Neil Cox. I'm formerly the Director of Prevention and Protection, moving into a new role now, so this is part of my handover to Catherine Wilmot, who's the new Interim Director of Adult Social Care, who will be joining us shortly.
Sarah Oley.
Good afternoon. No, that's right. My name's Sarah Oley. I'm the Directorate General Manager for iBeds, which is part of Primary Care, Community and Therapies here at Sandwell and West Birmingham Hospitals as well.
Richard Thompson.
Hi, I'm Richard Thompson. I'm the Pharmacy Lead for the Better Care Fund and currently working out the COVID Resilience team.
And we've got Deb. Would you like to introduce yourself?
Thank you, Chair. I'm Deb Breeden. I'm a Democratic Services Officer at Sandwell.
And I'd like to introduce our new member of the panel, Matt.
Yes, hello, I'm Matt Śliwiński and I'm also a Democratic Services Officer.
Okay. Have we got any apologies?
None received, Chair.
Okay.
Sorry, Chair. We did have a message come up during the meeting from John Taylor saying Health Watch send their apologies.
Okay, thank you.
I've made a note of those. Thanks, Councillor Piper.
Members to declare any interesting matters to be discussed at tonight's meeting? No. Okay, to confirm the minutes of the meeting held on the 14th of December as a true record. Anybody going to?
Move it, Chair.
Yeah.
Thank you. Item 4, any urgent business? Got any urgent business, Deb, to discuss?
No, Chair, but we have had a message from Valerie Allsworth, who's also in the meeting with us. I think you've missed a name off the bottom. Valerie, would you like to introduce yourself?
Would you like to introduce yourself, Valerie? I do apologise.
That's quite all right. Hello, I'm Valerie Unsworth, Service Manager for Health Protection Public Health.
Then we come on to our first item, COVID update. I'm handing over to Christine for this, I think. Or is it Neil?
I think it's me, but I'm doing it. We've got a very much a team effort today, Councillor Giles, if that's okay. I guess what we wanted to be able to demonstrate is all the work that we've done across health and social care has not been just one partner in isolation, that we've actually all worked really closely together as a genuine integrated team, which is why there's colleagues here today from other people from the council, including public health and adult social care, people from the CCG, as well as people from the Acute Hospital Trust, because without us all making an effort and working to the same processes, we don't believe that we would have had so much success. And today we want to be able to share some of that success and some of the things that we've been able to move forward on through this really difficult period. Can I ask Mike, first of all, just to make a few comments, and then we'll go into our presentation today, if that's okay?
Thanks, Chris. I just wanted to echo a few of the things that Chris has said there, and having joined this system about 5 months or so ago, and so therefore with some comparative experience, it genuinely feels like we are a well-integrated system that has a single purpose. The communication, I think, between our organisation has been excellent in recent months. It really feels like we've got some positive working relationships and a real shared focus, which plays out in terms of some of the things that we'll hear about this evening, in terms of the work we've done operationally around COVID and our response, how we've worked together on vaccinations, how we've worked together on discharge. And these are things that I'm really looking forward to continuing throughout the rest of the pandemic, but certainly beyond that, in terms of what we can do together, because the early signs, in terms of my early experience of this, has been incredibly positive. And so working with partners from the local authority, public health, etc., the commissioning organisations, has been fantastic to date. So I'll not bore you with that, because there's proper good detail that we can get into and that the teams can talk about in terms of the genuine changes and improvements that we've made. So without further ado, it's probably best we get into that. And back to Chris.
Thank you, Mike. We've got a lot of slides to share today, but because we've got a lot of presenters, hopefully it won't get too intimidating. We're going to ask Richard now if we can just share the slide pack. We're covering off 2 agenda items through these slides. One is our general response to COVID, and then there's some focus on how we've approached the vaccination to support the COVID effort as well. So I'm going to ask Richard, if I can, just to kick us off with the first few slides, and then we'll all come in when it feels like the right time, if that's okay. Thank you, Richard.
Okay, I'll just take you through the first part of this is the description really of the COVID resilience team. So the COVID resilience team was put together in March last year. It operates 7 days a week, and we provide support to the whole care provider market. There's a dedicated telephone number and email address for providers to get in touch with us. And this team is staffed by members of the council and the wider Better Care Fund team as well. And this slide just gives a bit of an overview of the areas that we've been supporting providers in. So we've been supporting providers in terms of access to PPE and triaging those requests, supporting providers where there are staffing pressures, and we have an escalation process that we can follow. And Chris will talk a little bit more in her slides about the support that's available to providers. We've contributed towards the overarching winter plan. We've certainly given detailed guidance and developed tools to support providers to interpret things like the national visiting policy so they can evidence they're meeting the requirements for that. There's a key role in cascading information to the market. So we have a provider bulletin, which is a system-wide approach, and then we also have a regular stream of communication when guidance and safety alerts are made available. We've provided similar guidance around testing and a number of medicine schemes, including the medicines reuse scheme and vitamin D, where we've worked collaboratively with CCG colleagues. One of the key tools we've used for this is the SAVE system. So SAVE is a bespoke system developed within Sandwell. It started as a tool to monitor market capacity, but it's very much developed during the pandemic to become the daily information tool for the whole system, really. So as well as the escalation point for pressures around PPE, staffing, through COVID resilience, it feeds the wider information requirements of commissioners within the council. It provides updates on positive cases to enable timely response from public health colleagues. It feeds the regional updates from a CCG perspective and across the STP, and it contains a number of clinical alerts for providers who may need assistance with deteriorating residents or where there are concerns about end-of-life care, so that they can be escalated to the appropriate community teams within Sandwell and West Birmingham. And it does this by a series of automated emails that fire out to the respective teams when the providers complete their daily SAVE return. The providers are required as a system and as individual entities to support something called the National Tracker, and what we've been able to do through SAVE is build in that requirement into the other information requirements for the system. So for care homes particularly this is, and we then have a mechanism for bulk uploading that information. Through that, we've managed to achieve a high level of provider engagement. We typically have around 90% of providers who use the tool completing it on a daily basis, and we have had interest from other areas as this is potentially an example of good practice to be shared. I'm going to hand over to Chris now to look at some of the things that are in place around commission.
Thank you, Richard. I think we've really acknowledged that it's been a really difficult time for providers, not only in Sandwell, but obviously across the country and across the world. But we've focused a lot of our efforts on care homes, because you will have all seen that the national press about the pressure that they've been experiencing. But all of our work has also been around supporting the domiciliary care market, extra care, supported living, so a whole range of providers that are out there in the market. And these are just a couple of examples really of how we felt that we've been able to respond to the messages that we've had through that means that Richard's just talked about, through the SAVE system, and being able to respond to be able to support providers. So the first one talks about a contingency carers contract. So we're working with a care agency, and we've got a group of staff that are there on call, that are funded to be able to respond when providers are actually struggling for care staff. That's primarily been accessed by care homes where staff have had to isolate, so they've had difficulty maintaining their staffing levels. But usefully, it's also been used to respond to crises in the community where perhaps there's been a couple and one of those members of the couple has been admitted to hospital. We've been able to deploy staff to stay with the person who's cared for to prevent them having to go into hospital or into care. So we've deployed these staff on a flexible basis to respond to what the demand is out there in the community. We've also increased our basic home care support. We've got an ethos, and we'll go into this a bit more detail, about discharge to assess and getting people home where we can. And to enable that to happen, we've more than doubled the capacity that we actually block purchase in the market from domiciliary care agencies, so we can provide that care for people in their own homes. Additionally, from a care home perspective, we've commissioned beds across both nursing and residential homes to support those people who are COVID positive, who've been in hospital or who've needed support from the community, but who need to complete their isolation period. So that we're not discharging people into every care home and running the risk of infection spreading. We're working with a number, 3 or 4 care homes, to actually say that they will support people who are COVID positive. They will take them in for their isolation period before we move them on to their next care setting, which hopefully would be home, or it may be another care home if their ongoing needs meet that requirement. Just to incentivise care providers to respond really quickly, we've actually offered an incentive and an additional payment if they can also respond on that day that someone is medically fit in hospital, so that we can get them out, because we are keen to not have people stuck in a hospital bed where they could be cared for more appropriately in the community, and all of the work that we do in supports that approach. Okay, Richard. There's been a number of both council driven but also government driven funding sources to actually make sure that we can support our providers in Sandwell to continue to provide that valuable support to our most vulnerable residents. And these are just a few of the examples, and I'm going to go just in a little bit more detail in each of these as we go forward now over the next few slides. So next slide, Richard, please. The first one is around what we call in our provider offer. So it's where, as a council, we're using some of the emergency monies that have been provided to support the social care market and to keep providers going through this really difficult period. We've broken this down into 3 levels. One is a bit of a core offer, so it's available to all providers. So that's about prompt payment, it's about support for transport and other areas. The second level is where we've offered particularly around service areas, so things like where care homes or dom care agencies have had people go into hospital, we've continued to pay for their placement for a longer period, hopefully so that we can get people back into those providers quickly if they have a short hospital stay. We've made significant contributions to PPE, and Richard touched on that initially with the COVID resilience line. Providers could ring in and then we would arrange for really prompt delivery or collection of PPE to all providers in the market. And we've had particular difficulties around daycare, and our daycare providers haven't actually been operating as a building-based service since March last year. But what we've done is continue to support those providers to provide a community alternative. So their staff have been used to actually go out and support people in their own homes and within the community as an alternative to attending day services as they traditionally have. The third level is what we call our more bespoke offer. So we've had an offer that says if we've got any providers that are suffering a financial viability issue, that they can come forward to us and we will try to support them to continue to maintain the service through this period and beyond. And so far, as you can see on the right hand side there, we've all invested £650,000 in actually supporting the market from the money that's been offered to the council for the COVID effort. Okay, Richard. The next 3 are all government funded grants that we've been receiving. The first one is the infection control funding, and we've had this in 2 tranches. And we have been told that we have to spend 75% of this money on care homes, and it's to make sure that care homes are doing all of they can to maximise their infection control measures and to prevent the spread of the COVID virus. So this is about ensuring that staff only work in one area or one unit. It's ensuring that staff, where they need to isolate, can isolate and can be paid their wages to do that. We've restricted transport for staff, or we've provided accommodation for staff where they've needed it. Now that's been a £6 million fund that we've sent out to providers in Sandwell, so a significant amount of money, but it has meant that we've been able to work really proactively, particularly with our care homes, and you'll see some of the impact of that hopefully in the slides that are to come further later on today. Okay, Richard. The next one is our Workforce Capacity Fund. This is a recent allocation from the government that's got to be spent by the end of March. This is £924,000 again to be distributed to care agencies, primarily care homes, but this is about where they've had significant numbers of staff who've had to isolate or have been COVID positive, so that they can maintain their staffing levels and they can continue to restrict that movement, so we haven't got carers moving from one site to another and potentially spreading that virus. So it's enabled carers to be continuing in their caring role, both within a domiciliary care setting as well as within a care home setting. Okay, Richard. The last one for me is again a recently allocated fund for what they're calling rapid testing, and these are the lateral flow tests. There's a picture there, it looks like a pregnancy test kit, but is a lateral flow test for COVID. We've been allocated £681,000, which again have got to be distributed to the care sector, primarily care homes. As it says there, 80% has to be spent on care homes. We're currently in the process of getting that money out to the market, and they've actually got to spend that by the end of March this year. And this is about training staff to be able to undertake lateral flow tests, testing that's actually taking place and the time that that actually takes, but also to support visitors actually moving into our care homes as soon as we're at a position where the transmission rate is such where that's safe to do so. So again, lots of investment that's coming into Sandwell, but it's absolutely needed to make sure that the sector can continue and they can continue to provide the care and support that they need to provide in a really safe way. Okay, Richard, do you want to go on to the next slide? And I think I'm going to ask my colleagues, Valerie and Marion, to come and comment on this slide if I can.
Thanks, Chris. So this is a slide that really summarises, I think, everything that Chris has just been talking about. So this is a slide that shows the COVID-19 deaths in care homes, and it's up to date until as of the 29th of January. Now, obviously, every death in a care home is a tragedy, but in Sandwell we can see that our death rates in care homes is a lot lower than it is in our neighbouring local authorities. So in Sandwell it's 25.6 deaths per 100,000, which is significantly lower than Dudley, Walsall, Wolverhampton and the England average. Every death is a tragedy, of course, but you know that we're not seeing fewer deaths by accident, and that's really down to a lot of the work that we've all been doing. And a lot of it is down to the fact that we've got cooperative working, we're all working together, we've got a couple of infection control nurses who provide the care homes with a great deal of support. And really, I think everything that Chris has just been talking about, all the support that we're offering the care homes, we can see that in this slide, and I think this is something we should all be very proud of.
Thank you, Valerie. Thank you. Marion, can I bring you in there as well, please, to just explain some of the other support that we've been providing to care homes?
Yeah, and stop me when you've heard enough, because I could go on all night about care homes. We didn't come into wave one cold. We had very good established relationships with the care home market from work we've done the previous 2 years, and we've got very good relationships across the system. So we went into wave one in a strong, when I talked to colleagues in other areas, I think we were ahead of the game in terms of knowing people and them knowing us. What we did, one of the first things we did was organise our district nursing services, remove some of the barriers around where they went in terms of nursing, care homes with nursing or care homes without. So rather than 9 teams going across the patch, we built up one dedicated team. And that was a really deliberate move to cut down the footprint in care homes, but really to build relationships. So we right-sized it as well, just so that the district nurses weren't just running in, doing the task, running out, that they're actually, while they were in there, they could take stock of what is happening in that home. And they were the eyes and ears really around what was going on, and early signs of needing to get more support. And post-COVID, I can't imagine we wouldn't keep that model, get great feedback from the care homes. And it's people that they're more than the nurse going in to do a task. Their colleagues, listening ear, nurturing, coaching, and it's mutually beneficial. We've got the wider care home team, which is a skilled team of case managers, advanced nurse practitioners, therapists, that gets a same day response. And again, this is something that you do not see uniformly across the country. I'm not saying people don't do it, but it's something people come and ask us about. We have got a really, and again, this isn't new to COVID. We've had this now for a couple of years. So to get responsive services in, so if somebody needs a same day speech and language assessment because of their swallowing, which could be the difference of keeping somebody at home or having to go to hospital, we can be really responsive. And then the wider engagement with our PCN colleagues, with the GPs, they worked very differently with us over COVID, and still, while we're in the midst of it, still are, around having weekly MDTs, multidisciplinary team meetings on WebEx or Teams, where the care homes, the MDT team and the GPs are there talking about people they're worried about. And again, I say that now really casually, we're all doing team meetings, you know, and I look to Claire Blackburn and her colleagues of getting the hardware and the IT support so that we could work in this way, because that was brand new for everybody really, but it has really changed how we have our conversations and our meetings. We've also got palliative care that are plugged into these meetings. So again, you can do the high level planning and then out of those meetings start doing the detail with people who need it, and of course involving relatives and advocacy as needed. Lots of training again and the benefit is it's training from people who know them around PPE, donning and doffing, fit testing, end of life planning, and IPC, infection prevention and control, and again working with Valerie's team so that we're not all duplicating effort. And the principle was where we could keep people in the home safely, that's what we'd do. So that was the proactive element. And then the reactive element that we also enhanced was admission avoidance. The CCG funded the epicentre model, which for the first time brought an acute physician out to work with admission avoidance to really enhance the clinical management of people in care homes. Lots of prescribing function, so a really responsive service. Lots of outbreak management and support, and lots of support with swabbing if an outbreak was suspected. What we also developed was LISOs as an end-of-life centre. Really, again, ramped up the nursing and the palliative care specialism in there. So if people couldn't return back to their nursing home because of their COVID status, what they could have was a care closer to home in a more homely environment. So lots of people died sadly at LISOs who would have gone back to their home had they not been COVID positive. And then the other thing really, just to say, we also offered up in wave one was our trust has an amazing package of care for staff, recognising the burden of all this on staff's resilience, and that was opened up to the care homes very early on around all the support that we can access, the homes can, and we've had some really good feedback from some of the home managers on that. And the other thing is bereavement support. Staff have in the care homes obviously losing colleagues, losing their own relatives and losing their residents that have benefited from again having our bereavement support through our palliative care team, nurses and doctors. So that's a whistle-stop tour really of what we did. What we're doing in wave two is really ramping up the remote monitoring. Wave one, we did lots of work on training care home staff how to take a set of clinical observations reliably so that we could make decisions remotely and to advise when people. This isn't about keeping people out of hospital who need to be in hospital, but it's making the right decision for that individual where we can. So we did lots of work on helping staff recognise signs of deterioration, the soft signs and the clinical observations, and getting kit out to them. So at the moment now we're really majoring on getting the pulse oximeters into the residential homes, whereas before it was just the care homes with nursing, and training the staff to be able to monitor oxygen saturation, the things that can make the difference of whether you keep somebody in the care home or actually facilitate an acute admission. And that's pretty much it in a nutshell, what we've all been up to. But we've had great support and a real from the CCG and the council, where there's things that need unblocking and solutions or money, there's just been no barriers. So in many ways there's been some great benefits of how we're all working together that will carry on. Thank you.
Thanks, Marion. I think you get a feeling of how passionate we all are about this and how we really do want to make a difference. So I'm going to ask Richard to pick it up again now, if we can, and to focus on our approach to vaccinations. So over to you, Richard. Thanks.
Thanks, Chris. So this next set of slides are running through the approach we've taken to particularly adult social care and care home staff in part of the first two cohorts. So the Joint Committee on Vaccination and Immunisation, which is the government body that sets the priorities for vaccination, identified residents in care homes for older adults and their carers as the highest priority group for vaccination. And in cohort 2, they included those that all those that were over 80 years of age and frontline health and social care workers. It's really important to emphasise that within this definition, the scope within the National Standing Operating Procedure for frontline social care workers is a broad one. It isn't just the traditional roles that we would expect, it is other social care workers who are working directly with people who are vulnerable to COVID-19. And it applies regardless really of where they work and also who they're employed by, and that is part of the size of the task that faces us. There is also consideration of prioritisation to include consideration of risk, and that's the risk to the individuals in contracting COVID-19, the risk of the serious complications that may ensue from contracting COVID-19, and also the risk of onward transmission. So those things are factored into some of the decision making that goes around the prioritisation for this. And the guidance is really clear that there's a role for local authorities in identifying those cohorts of eligible staff, working closely with our providers and also those providers that we maybe don't have an established relationship with, and also other employers of social care staff. And that's where we come to look at people who are employing personal assistants as well. Just to give a sense of the size of the scale of this task, this is data based on the services that are registered with CQC within the Sandwell footprint, and this was data drawn down in the middle of January. So we have around 2,600 employed care staff and nurses in our care homes, around 500 employed non-care staff, and a small cohort of regular agency staff in those homes. And then across domiciliary care, it's estimated we have around 4,200 staff delivering care. In reference to those groups holding either a direct payment from the council or a personal health budget from the CCG, there are around 550 individuals, and that equates to a personal assistant workforce of around 800 employed carers. And as I said in the first slide, cohort 2 includes a wide definition of social care workers and colleagues providing equivalent care functions in the voluntary sector. And our delivery model includes a range of options from local hospital sites, the primary care model that's reaching into care homes, and also the new vaccination sites like the site at the Black Country Living Museum. In terms of prioritisation, there has needed to be prioritisation as we've had availability of vaccine supply. Providers have been targeted via proactive engagement. So looking at cohort 1, which is our older people's care homes, thinking about the staff for those, particularly in terms of this prioritisation, because the vaccination was picked up by primary care colleagues. Initial invitations went out to staff at homes providing care to COVID positive individuals on discharge. So these are the designated sites that Chris referred to in the commissioning slides. So these are homes that are taking a higher number of COVID positive individuals because they're taking people who are completing their isolation out in the community. We then extended the offer through to our staff in our enhanced assessment bed provision, so we could ensure that the flow out of hospital was as resilient as it could be, and then it's been further extended to our remaining care homes, including homes that are now in cohort 2, so those homes that are catering for working age adults, so adults with learning disabilities or mental health needs, for example. For cohort 2, our first phase commenced early January, and again, using the risk-based approach, we targeted the domiciliary care providers who were accepting COVID positive individuals, particularly those accepting them on discharge. We also looked at our extra care provision, closed environments that predominantly are housing older people, and we looked at the internal and external provision for those, and also looked at our supported living services, which are housing vulnerable adults, again in closed environments, so thinking about how it aligned with some of our care home modelling. Second phase, which commenced a few days later as capacity was available, it was looking at the remainder of the domiciliary care providers and looking at the wider provider market, so our voluntary sector, our daycare and our personal assistants, and a wider cohort of social care staff. Next couple of slides just give a sense of where we are with the uptake. For the care homes, we have a system via SAVE and via the national tracker for providers to report their uptake information. So this data was pulled down at 5 o'clock yesterday evening. And shows that we've currently got 81% of our care home residents where we've had a confirmed response have received their first dose of vaccine. For directly employed staff, the response is currently lower at 48%, but overall across our care homes, thinking of staff and residents, we have a 60% coverage so far with the vaccine. We do have some more detailed information from 75 homes who use the SAVE system, also providing some information on the sort of definitive refusal of the vaccine, and thankfully those numbers are very low. So we're seeing for residents around 4% and for staff around 8% are actually actively declining having the vaccine. In terms of our internal provision, Fountain Court is the council's residential care home, and there 100% of the residents have been vaccinated and 84% of the staff have received the vaccine so far. There are a number of things that are feeding into the delay in uptake. So aside from the refusals as detailed above, there are a number of staff within these settings who their vaccination status is unknown. It may be that they haven't yet disclosed their vaccination status to their employer, and there are also some delays. So we've had homes with active outbreaks recently, and there is a 28-day gap required if you've had COVID infection before you can actually go and have your vaccine. And also, as I alluded to in the earlier slides, staff in the homes for working age adults were included in cohort 2. So some of those homes will have been targeted later by the in-reach teams from primary care. Looking at non-residential services, we have a slightly less clear picture at this point in time. So the tool that the providers are asked to complete was changed last week. So we're starting to see an emerging picture from the new questions that they're being asked to complete. We have been keeping a log of those providers that we've made contact with to actively invite. So of 113 providers where we've sent out invitations, we've had responses from 51 of those as of Friday morning, which identified just over 1,700 staff who wanted the vaccine and around 260 who were declining the vaccine, although we don't have refusal data from all of the providers. From the national data, which again was pulled yesterday evening, 35 providers have completed the tracker since it was changed last week. That was just over 2,400 staff identified as providing care, and of those, just over 1,900 staff have had the vaccine offered to them, and 680 have taken up or confirmed that they've taken up that dose. And again, we have a cohort in there with unknown vaccination status, and we also have some anomalies in the data in terms of the vaccine that's been offered, where there are just some inconsistencies in how the data has been reported. So providers have completed that staff have received vaccine, but they haven't completed the corresponding column to say they've actually offered the vaccine in the first place. For our internal extra care services, the Granges, there 68 staff have received the first dose of vaccination so far, so that's 80%. A further 8 are pending and 9 have refused. And there are some complex reasons for people refusing the vaccine, and we've been trying to monitor these and work with public health colleagues in collaboration to develop some tools and responses to try and increase the conversion rate. because of the speed that the vaccine's been developed, although it's a great scientific achievement, it's actually created for some people a sense of uncertainty about the rigour that's been applied to the testing and the approvals process. Although the MHRA, who approve medicines for human use in the UK, have been very clear that they've applied the rigorous process to the vaccine, I think the speed has caused that uncertainty for some people. There are also some recurring themes around concerns around pregnancy and fertility concerns, which, given some of the demographics in the workforce, are particularly pertinent. Some people have cited medical reasons, and some of the ones where we know that people are pending vaccination, it's because they want to discuss the issue of vaccination with people involved in their own medical care before they come forward. The side effect concerns and adverse effects from previous vaccines, that's been a recurrent theme in those that have provided responses as to why they won't have the vaccine. And again, we're working with colleagues to try and share some more positive information about the likelihood of those occurring. Anecdotally, we're seeing some preference for a specific vaccine. So we've had a number of people come forward asking for the Oxford vaccine. The vaccination hubs that we've been using to date at the hospital sites have had access to the Pfizer vaccine. So that again is something that we're working through. Obviously, as the vaccine becomes more available in the community, providers will have the option of directing staff to other vaccination sites which will have different supplies available to them. There are some challenges around protected beliefs, and I think we have to acknowledge that the misinformation that's available on social media is a barrier that we have to overcome, and it is something that resonates very strongly for some people, and it's really key that we get some of those messages out there. And we've been sharing webinars that are available by regional colleagues to try and give staff opportunities, and we're also doing some work with public health colleagues to look at homes, particularly where we've got low uptake, to see whether there are some key pieces of learning and some key ways of challenging some of those messages. And there are a small number of people who are citing personal reasons, needle phobia, or just general personal objections to vaccination.
Okay, Richard, thank you for that. I'm just going to ask Valerie to come forward now and just give us a bit more information about public health and the support they've been offering. Thanks, Valerie.
Thanks, Chris. Next slide, please, Richard. So thank you. I'm just going to do a very quick high overview of the public health acute COVID response, really just to explain how we fit into all of this. So we are running a 7-day-a-week service, so the same as adult social care. We cover weekends as well, and we've been doing that for what seems like a very long time now, since I think certainly since the summer, April time. In the weekend, we have somebody working at consultant level, so myself or one of the consultants in public health. In the week, we have a consultant-led service, but we also have other members of staff who work on the COVID response. And really, we're dealing with any inquiry that comes in that relates to COVID health and public health and COVID. And that can probably be broken down into 4 main work areas. So we do a lot of work with schools, even though the schools are closed now, some of them are still open, and for children, vulnerable children, children of key workers. And schools have taken up, have been very busy, and there's been a lot of outbreaks and situations in the schools over the year. So that's something that we've been working very closely with the education department to support the schools and to support the head teachers across Sandwell. We've done a lot of work again with workplaces. So there have been a few outbreaks in workplaces. Many of them, or some of them, have made the press and the local media. And again, we've been working with businesses and supporting them to make sure that they're COVID secure, to make sure that their risk assessments are in place. And if they do get outbreaks or cases or cross-infection, that they're able to manage that. So again, that's collaborative working with environmental health officers, trading standards, health and safety executive. Of course, care homes, and we've worked really closely, public health, with adult social care and with Marion and her team at SWAB, doing a lot of work supporting the care homes that really have the most vulnerable people in Sandwell living in them. So that's something that we've all worked very closely together, and we've got infection control nurses, and we provide a great deal of support to the care homes. We get a lot of general inquiries that don't really fit into any one of those categories. Every time the national guidance changes, we get a flurry of inquiries asking, can we do this, can we do that, what does this mean? And so a lot of our time is perhaps taken up interpreting the national government guidance and explaining to people what they can and can't do. And then outbreaks and IMTs, that's my jargon, so sorry about that, that's incident management teams. We work very closely with Public Health England, and we've actually taken on a lot of the work that Public Health England traditionally did, managing and leading outbreaks. So if there's an outbreak in a care home or a school or a workplace, that is often run by Public Health, and we're chairing the meetings and making sure that the public health is being protected. So that's pretty much what we've been doing with our COVID response. Next slide, please. So that was the acute COVID response. These are some more areas of key kind of work areas that we've been involved with. Obviously vaccinations, so we've worked very closely with Richard, with Adult Social Care, looking at this. Richard touched on some of the issues that people have raised about not wanting to get a vaccine, and we're really working hard to try and overcome some of these barriers. So we're doing a lot of work at the moment within community engagement. We want to get key people who are respected leaders in Sandwell. We want to get them on board. We want to get them talking to people about vaccination and making sure that people are making informed choices. So we've actually got a couple of sessions this week with them to really help them to spread the word about vaccine. And I did an all-staff briefing, I think it was last week, across the council. And again, similar principle. We employ a large number of staff who live and work in Sandwell. We want to train up an army of staff who are going to be talking positively about vaccination and try and get people to get the vaccine if they were perhaps a little bit concerned. I hope you can still hear me. I've got some slight network problems, so if I disappear, I do apologise. We've done a lot of work about testing, and again working with colleagues across the sector to make sure that people can get PCR testing or also lateral flow testing. Contact tracing, this is something we did very early on in public health in Sandwell. We know that there's been challenges with the national track and trace, and that's been well reported. So one of the things we did in Sandwell quite early was get our own contact tracing system up and running and in place. And that, again, it's a 7-day-a-week service, and that's contacting people who are hard to reach, who've not been contacted by the national system. And this is obviously really important to make sure that people who are contacts or who are cases are not going out and about and spreading infection. And of course, that's even more important now than ever because of the South African strain, which we know is local, and we are very concerned about, and we're keeping an eye. We're doing a lot of proactive work. It's not all reactive. So a lot of work we do is about risk assessments, and it's about helping people assess the risks in their area, whether it's a workplace or a school, and making sure that the controls are in place to manage those risks and to reduce the risk to people. We're involved with planning for the elections that are coming up in May to make sure that they can happen in a safe way. And then obviously education, we've done a huge amount of work with schools. So really, I think that's it from me. Next slide, Richard. Yes, that is it. So that's just an overview of what we've been doing in public health over the last few months.
Valerie, thank you very much. Councillor Giles, I just wondered, would you like us to pause there for some questions? I'm conscious that we've been talking for a long time. We've got some further slides about the discharge to assess process, but I think we're happy to take questions now if people would want to.
I think we'll take questions now. Has anybody got any questions? I've got one anyway to start off. How many care homes have we got positive cases in? I know of one, but how many others?
Right, Richard, do you want to pick that up for now? I'm conscious that that changes on a day-to-day basis, Chair, because obviously we have different infections in care homes, different outbreaks. We deal with those and we support the providers to move through those and to prevent any further extension of infection. But it is a moving feast. Richard or Valerie, do you want to touch on that now?
I don't have that data to hand. I can see.
I don't have that to hand either, but again, I would just reiterate what Chris has said. It will change very on a daily basis, really, and I would imagine that most of our care homes have, at some point since February, March, had positive cases, if not all of them.
Okay, Councillor Costigan.
Yeah. Thank you, Chair. Just a couple of comments and a question from me, one to Christine really. Obviously, firstly, I'd like to say, obviously, the good news and the good work that you are doing is tremendous, to be honest with you. And I must say that the district nurses have always been special in my eyes, but even more now. The question I'd like to ask Christine is, you mentioned the rapid testing. I don't know whether you can, but it would just be good to have figures. You know, is there any figures that you can give us?
With the rapid flow tests, we get, there must be many hundreds, thousands, where care homes generally have to do 2 tests a week for all of their staff and a test for all of their residents. Where we do have outbreaks, that increases to a daily test for all of the staff, so that we can keep a really close eye on the infection levels within the care homes, and to make sure that any staff that are testing positive are obviously removed from that environment and are isolated. I think we can certainly come back with details about the number of tests as a best guess, but again, I don't know if Richard and Valerie want to come in there. I suspect it's significant numbers.
It is, and it will be significant numbers of repeat tests as well, but I don't have that data either, I'm afraid.
Just interesting, really. Thank you.
Okay. Dave Bradshaw. Want to ask?
Hi. Yeah, could I just ask, please, just in terms of the rollout of vaccinations for care home staff and residents, what is that impact in terms of returning to, you know, sort of visits being allowed and those sort of things? What's the kind of the status of play in terms of that?
Valerie, do you want to touch on that one?
So we're very much guided by the national guidance with this, but certainly the stance with vaccination, whether it's care homes, visitors, or any other area of life, is vaccination doesn't actually change any of the current public health measures. So what we don't know at the moment is if you've been vaccinated against COVID-19, we know that will significantly reduce the chances of you becoming ill or seriously ill with COVID-19. What we don't know is if that stops you spreading COVID-19, and it's quite possible that somebody who's been vaccinated can still spread the virus to other people. So until we learn a little bit more about how the vaccines work at reducing spread across populations, it doesn't really change anything to do with the visiting in care homes. That may change as we move forward and we've got more information, but right now it hasn't changed anything.
Okay. Councillor Carmichael.
Thank you, Chair. I just have a few questions, if that's okay.
Yeah, it's fine.
The first one's to Christine, well, the first two are to Christine, I suppose. So I want to know how many domiciliary care providers that we have, and how is that funding being split between them? Have they all had an equal share, or does it vary?
It's varied depending on the number of customers they're actually supporting. So when we've been required to break down the allocation, for instance, in the infection control fund that we've had, there's been a requirement for a certain percentage to be spent on care homes, and then we've used the remainder to support the rest of the market. When it comes to domiciliary care, it's been based on the number of people they're actually supporting, and that's been based on the CQC data that we've actually been provided with. So again, we've tried to make sure that it's as equitable as possible. So we've made sure that it has gone out to the whole of the market.
Okay, so we have a lot of care providers, is that what I'm...
We do have a lot of care providers,
okay.
Yes.
Is there any chance that we can have a figure on the next meeting or something? Not
yeah, I don't know if Richard's got the figure to hand there, because the difference with some of this is some of it is people that we commission to provide care. Some of it is providers that are based in Sandwell as a footprint, but we don't actually work with. When we've been provided with this funding from the government, we've had to provide the resource to all of the providers within our patch. So some of the providers were actually new providers to us. So that number varies depending on whether it's people that we're working with, total number of providers who we're actually commissioning with at any one time. I don't know if you've got any figures, Richard, latest there. You're on silent, Richard.
So we're doing two things at once, just bringing up the CQC data as we speak. So we're looking at an approximate figure of around, well, just short of 90 domiciliary providers, which vary from very large providers through to much smaller organisations. Some of those we have significant relationships with, and some of those we've had to reach out to through the pandemic period and obtain contact details from, because they are just not visible to us from any kind of contractual relationship previously.
Okay, thank you. Is Christine still on?
I am, yes, I'm still here.
Yeah. Okay. With the £6 million fund for the care homes, is that both for council and private homes in the area?
It's all care. It's all care providers. So again, there was a requirement for a proportion of that money to be spent on care homes, but that's every care home that's registered within Sandwell. So again, based on the CQC data, but then it's also a requirement that we support the rest of the market. So it has included domiciliary care, extra care, supported living, as well as.
I'm just so confused by all these grants. We've got 650,000, and I'm just trying to work it out in my own head, really, more or less.
I think it's been really quite difficult because we don't get to hear about them until quite late, and then we have a very short period to get the money out and for the providers to actually spend it. So it has put us under a lot of pressure to make sure that we've got those established details and the links with the providers so that we can get the money out quickly, and they have to do returns to us. And if they don't return to us, then they don't get any more money. So there's a whole industry that's around monitoring this. So it is quite complicated.
Okay, so the final grant then, the 924k, which was the workforce capacity fund, should that have gone to the staff, or does that go to the business? So should the staff receive?
It goes to the business, but then they can pay it to their staff. So it could be that staff might need to do overtime. It could be that they can pay staff to work when they should be off, so extra days. It could be to pay staff for their childcare arrangements so that they can work extra shifts. So the money is going to the staff, but it's going via the care providers.
Okay, but we monitor that to make sure that the staff have it. Is that right?
They have to do a return to us that we then have to send to the government as how they're spending it.
Right, okay. Right. And my final question is to Richard. Where's the PHP direct payment come from? Where is there another grant?
No, the direct payment in PHP is a way that people can fund their care rather than having commission care. They have the budget that would have been attached to their care allocated to them for them to employ staff directly. So it can apply to social care packages and to people that are eligible to continuing health care. So in effect, either the person receiving care or their representative becomes the employer of a bespoke team of staff for their needs.
Okay. Thank you.
Thank you.
Thank you.
Mr. Jones?
Yeah, I've got a question about PPE. I know that we've spent a lot on PPE over the past year, and we've had to adapt to the ever-changing situation. Appears now that that coughing is now considered as an APG, and that a fluid-resistant mask might not be sufficient in protecting members of staff from transmission of COVID. Are we reacting to this to make sure that members of staff who are with positive coughing COVID patients are now able to wear a suitable level of PPE, such as an FFP3, or are we waiting for the government and Public Health England to change their guidance, which could be, who knows, in a couple of months' time? Are we going to be reactive in a positive way, or are we just going to wait for guidance to change? Sorry.
That's okay. Valerie, can I bring you in there for that as initial response?
Yeah, sure. So there's evidence. The evidence isn't great. That there is some new evidence that suggests that the virus is transmitted by aerosols, which we've known for a little while now, and it's whether that requires the additional FFP3 mask that you mentioned. To answer the question very quickly, we're waiting. We follow national guidance. So if Public Health England publish guidance that require FFP3 masks, then that is what we will recommend and advise. I know that Marion and some of the homes where patients have been admitted directly from hospital with COVID, they are wearing FFP3 masks all the time. In the rest of the homes we're using the fluid repellent surgical masks. It's never quite as straightforward and clear cut. The FFP3 masks are effective, or rather I should say the respirator masks are effective, but there's lots of different types of them, and you have to wear one that you've been trained in and fitted for your particular use. And that is quite a labour intensive process, and there are some people who have beards, or often women who have smaller faces. They don't fit any particular mask, so it's not a simple undertaking. But I think the answer to the question is we absolutely follow what the national guidance is, and if that changes, then so will our advice.
Thank you very much.
Coming back on discharging people from hospital who are COVID positive, is it just certain homes they're going to, or I know you said special care homes?
Yeah, we've got what we call designated settings. So the government required us to work with care homes to agree who would take the people who are still COVID positive or coming out of hospital. So we've got arrangements with a number of care homes across Sandwell where we do place them, where they complete their isolation period, and then they'd be moved on to another placement after that. So yes, we do work with certain number of care homes, and just so that we're clear, they do tend to wear the FFP3 masks because they are working with people who are absolutely COVID positive in a very small environment.
And we ain't had any big breakouts in those homes?
I think it's fair to say we've had breakouts at different times in virtually all of the care homes, it's not necessarily been predicted or predictable. So we have got outbreaks in different care homes, but where we've got designated settings, we've got also designated areas within the care home where those residents are actually supported. So they don't mix with the rest of the residents within that wider care home. They are absolutely isolated within a small area that is separate from the rest of the care home. So there isn't a risk of transmission from the people who are coming in as COVID positive to the rest of the residents in that care home.
Okay, thank you. One more question. How are we getting the people who at home who've got carers going over 80s or over 70s the vaccination if they can't get out? Are we district nurses going in, or?
Well, can I bring Marion in there, because I know she's been supporting in some of that. Marion, are you there?
I am, yeah, subject close to our hearts. We're in active partnership with the GP practices, firstly maximising people's opportunities to get to a hub, and if not, nurses, yes, district nurses, community nurses. We've also got a training programme for therapists, so whoever whatever clinician we can free up, we'll support. So there's circa 2,500 housebound over 80s, and we're hoping that we believe everyone's on track with some risk to be completed by the 15th of February. But it's a mammoth undertaking, because it's not as easy as saying 2,500 of those will know them as district nurses, but because the vials have 11 doses in them, it's not like the flu jab where the district nurse could just load up and go off for the day as part of their daily. This is a focused piece of work. So yeah, the logistics behind it, like everything, are quite complex, but yeah, we're working together 7 days a week to get the housebound folk of all ages really vaccinated.
Okay, thank you. Any more questions? No, we'll move on. I think David Carruthers is going to give us an update from the hospitals.
Oh, sorry, Councillor Giles, we've still got some of the discharge to assess
Oh,
information to
doing that
share, if
first.
that's okay.
Yeah, that's
Richard, do you
fine.
want, thank you. Richard, do you want to share the slides? And I'm going to pass over to Sarah and Claire, who are going to take you through this.
Thank you. So good evening again, everybody. So I just want to start talking you through the discharge to assess model, which you've heard already mentioned this evening. We'll just elaborate on that a little bit. So just as a start off, this is very much a presentation on behalf of the whole health and social care system. And this has been very much an integrated health and social care initiative for us. It's a new model of working towards hospital discharge. And it's for us now in line with national response to the pressures that we've seen across COVID-19. The discharge to assess model has been in existence across the country in pockets for probably about the last 5 years, but with an increasing evidence base since August last year, it's now become nationally mandated. So I'll take you into an overview of the D2A approach, both nationally and what we've done locally, and then Claire's going to go on to talk about a little bit more about what we've changed locally regarding our practice and how we've worked together. So the underpinning D2A ethos, really, as I talk you through it, really focuses on 2 questions, which are why not home and why not today? And our emphasis on driving down delays for people who are waiting in hospital to be discharged into the community. And there's a strong evidence base that underpins that we get much better outcomes for the people involved if they return to their own home and aren't delayed in a hospital setting. So the ethos is around the fact that acute hospitals must now discharge all people who no longer need acute care as soon as they're clinically safe to do so. We talk in our teams about the patient going home on the day that they're medically optimised. That's what we're working towards. That's requires community response and intermediate care services to deliver extra support, ideally in a person's own home wherever possible. And we talk about a home first mindset, so challenging why someone can't go home before we move to any further institutionalised setting. If that other setting might be required, then the end point remains to try and get that person home as soon as possible and as safely as possible. So even if someone moves into a temporary 24-hour care environment, we're still looking to get them home ultimately if we can do. Part of the difference with this model is that social care needs assessment and NHS continuing healthcare assessments of eligibility are now made in the community rather than in our acute hospitals, and that really helps to drive down the delays because those assessments now don't need to take place before we can safely discharge the person. And Claire will go on to talk about this in a bit more detail, but the government's made some additional funding available to support us in our ability to deliver this. And that's really driven our ability to work together as a systems approach, that additional funding. It really does rely on full synchronisation, and we talk about integrated systems a lot, but actually in order to do this we have to work together in a really cohesive way day in, day out, which I'm pleased to say we absolutely do. So we have a really strong team of social care acute staff and staff in the community all pulling together towards the same goal of ultimate patient safety and quality. So with this home first focus is what we're really focusing on here. So next slide, please, Richard. One of the key things that's changed for us and is a real benefit is the change in the language that we talk about in terms of discharge. So this is an infographic, you can see how I'll just talk you through it. So a pathway, we talk about pathways 0 to 3 nationally, and I'll mention at the end that we add on a pathway 4 locally. So pathway 0 would mean that somebody has come into hospital, they only have an acute medical need, and when they're ready to go home from a medical perspective, they go home with no need for additional input and from health and social care. So what we describe as a simple discharge. The pathways are linked to the discharge destination. So again, for pathway 1, people are still going home, but in order to support that safely, they may well need health or social care input. So typically a package of care or some rehabilitation at home. Pathway 2 is around a temporary use of a rehab setting or further assessment bed, which means that they ultimately, again, we'd be looking at getting them home, but they can't go straight back into their home environment. And pathway 3, we use in a very limited circumstances where it's clear that through a life-changing event, for example, someone's not going to be able to return to their own home. And against all of those pathways, we can see there's a percentage target that we work towards in terms of how many people should be on each pathway. So 50% and 45% looking at 0 and 1. So 95% of our discharges should be going to their own home, just 4% into a temporary bed and only 1% into pathway 3. And then it's worth adding here that because we've got such exceptional palliative care and end-of-life services in Sandwell, we've decided to create an additional pathway for those people. So pathway 4 we use for people at the end of life, so that we demarcate those services and it's not confused by any differences that might apply to them if they have end-of-life services involved. So I think I'm going to hand over to Claire now.
Okay, thanks, Sarah. So I'm just going to run through, going on from Sarah's outline around what we've done differently since the guidance was released. So discharge to assess guidance was released in September of last year. It's national guidance that's mandated. And as Sarah outlined, it's the medically optimised people. So once they've finished their acute care and are ready to go, it's that rapid discharge safely to the most appropriate environment for them. So how we've done that is a daily list is shared twice a day, in the morning and in the afternoon, of people who are deemed medically optimised. From the 26th of October, we have had twice daily calls from the entire system, as Sarah said. So it's got acute colleagues on there, CCG, CHC colleagues, discharge nurses, and then colleagues from Sandwell Council. And those calls discuss what that person's need is in order to be able to be discharged and the coordination of elements that required to make that discharge safe. We also have a community pathway call twice weekly, and that is to go through everybody that has been discharged into pathway 1, 2 or 3, not 3, sorry, 1 or 2, to look at how can we optimise their discharge out of those services, preferably to home again. But those calls are there to facilitate the flow so that we don't just fill up pathways 1 and 2 and then have people blocked. So it's a constant review of the people on those services and on those lists to make sure that they're going to the most appropriate discharge destination for them. We also have a discharge to assess board that's held every Friday, and that has got executive membership from the 3 organisations, so from the CCG, from the council and the Acute Trust. And that's where we talk around what blocks are in place, what do we need to do differently, are there any funding requirements that we need help with in order to keep this moving as smoothly as we can. And discharge to assess runs over 7 days, so that's a big change for us as well. What isn't changing is people's roles aren't changing, however the need to work over 7 days is a requirement. Next slide please, Richard. Thank you. So as Sarah stated, there is national funding that is behind this guidance. So from the 1st of September, there's been national funding that we can draw down through monthly claims. And the funding is available for the cost of the discharge recovery and support services for up to a maximum of 6 weeks. And the idea is that funding would help people return to the quality of life they had prior to their admission. So that funding isn't instead of CCG and council funding, it's to provide the additional resources on top in order to be able to make that shift to caring for people within their own homes wherever possible. Alongside that, there's enhanced admission avoidance provision, which is also funded through this budget, so that if people are discharged or are at risk of readmission or admission from community, that we have an enhanced service that can wrap around them within their own home from health and social care in order to keep them as safe as possible, and where appropriate, avoid a hospital admission if it's not needed. So as I've said, it's not instead of, it's additional funding to increase capacity. And as Sarah alluded to, the assessments for eligibility of funding is no longer taken in acute care, it's taken when a person arrives in community care. So we're not holding people just so that their funding can be established. And the other thing to say is that the funding doesn't pay for long-term care. It pays for that additional capacity need for up to a maximum of 6 weeks in order to be able to get people to their most appropriate destination. Next slide, please, Richard. So to date, bearing in mind data monitoring began on the 26th of October, the number of medically optimised patients waiting in acute care has reduced from 57 to 27 patients daily. So that's a reduction of 47%. And that's quite impressive given the length of time that we've been working on this, which hasn't been that long. The average time from a patient being medically optimised to being discharged has reduced from an historical 7.6 days to 4.45 days. And by pathway, the most notable reduction has been pathway 1, which is people going back to their own home with community support, either from health and or social care. And that's seen an average time to discharge reduced from 8.8 days to 3.4 days, which is a reduction of 61%. There's another slide, please, Richard.
Yes, thank you, Claire and Sarah, for that. And I really, just to conclude, because I know you've been listening a long time, I think we just want to say we've come together, we've worked together on this, we've learned together, and I think we're all really committed to continue to do the best that we can for the people of Sandwell. So thank you for listening today. We do appreciate your time. Any other questions?
Thank you for the reports and all your good work. Any questions? Bob Piper?
Yeah, it isn't so much a question really, Elaine, but to echo what you've just said, and that's to thank everybody for the fantastic amount of work they're doing and doing it in such a joined up way, really. Much appreciated.
Thank you.
Yeah. Councillor Jones?
Yeah, my first-hand experience of this service as a paramedic is excellent within Sandwell. You really do take the patient from the hospital back into home really quickly, which helps with the strain and the pressure on the service as a paramedic. I just wish that other sort of authorities would use your examples as a shining example locally, because we do have a lot of problems. So thank you very much for doing what you're doing. It's excellent.
Okay, thank you. Now, I think David Carruthers has got a report to bring to us.
Hi, thank you. I do indeed. Let me just share something, shall I? Said he, hopefully. There we go. You can all see that. So what I'll do is I think I'll just talk to this slide. I think that's probably the easiest thing because a lot of the other information is fairly similar to what's been discussed already. And this graph is just showing reflection of the sort of data we collect for COVID cases seen at the two main hospital sites and Rowley as well, with Sandwell and City hospitals, going back to the start of the first wave back in March. I think what we'll start with, if you look at the red line first of all, this is the number of patients admitted to the hospitals with COVID. So you can see that people talk about peak and being busy in January, but the organisation was very busy in November as well. And notably, that was more admissions than we had in March and April during the first wave. The real difference, though, is that within this second and third peak, we've also had a significant number of non-COVID patients within the organisation, to the extent that we've had to expand our bed base using all available wards within the organisation and using the surgical ward bed base for COVID-related admissions. And I think the number of COVID patients was over 50%, close to 60% at one stage of all patients within the hospital. Whereas back in March, there were very few non-COVID patients in the hospitals. The hospital's been very busy, I think is what I'm saying, both with COVID and non-COVID related patients. If you look at the green line at the bottom, there's really very little to see there, but this is the number of patients admitted to intensive care unit. And I think, again, though it's difficult to see, you can actually see that in January, this line is above the baseline, showing that, or reflecting the number of patients we've had in ITU, which has been at 220% capacity at maximum. We've had to over double the number of beds and staff, more importantly, available to look after patients. And this is a phenomenal effort and the commitment of work done from nursing, medical administration, allied health professional teams to look after patients in all these environments. And we've had support from local trusts in transferring patients, particularly intensive care patients, but we're also transferring patients outside region as well, where there is capacity to create capacity within our region. And then we get to the slightly more depressing lines, and the thick blue line here is the number of patients, unfortunately, who have died from COVID within the organisation, which is just on this line now, it's just shy of 1,000 within Sandwell West Birmingham, and you can see the rapid rise in cases that's occurred through January into early February as community rates have been very high and the median age of patients admitted has increased. But there also, this isn't just an illness that is shortening the lives of elderly patients. There are many younger patients into our ITU who have unfortunately also passed away in their 40s and 50s and some younger. And the top line is, again, is an important reflection of the challenges we've had, because this is the number of staff who have been off sick with COVID. And as the community rates have risen and the hospital admission rates have risen, so have our staff sickness from COVID as well. And we're working very hard to make sure that doesn't become a problem for patients in the organisation, with regular testing of staff, with lateral flow testing we heard about in the care homes, and self-isolation of staff and contacts, but also appropriate use of PPE. That's led to us altering some of our guidance on use of PPE in the organisation. But yeah, so at the moment, we've got 324 COVID patients in, and it peaked at about 430. And the number of patients in ICU is fortunately down with COVID down to 27, while we were at 41 at our peak time in mid-January. So it's just a reflection of how some of the data and what we've been dealing and managing with in the hospital, and the hard work of the teams to provide the best care both to COVID and to the non-COVID patients, which are now 60% of our patients in hospital. I'll maybe just leave it there because there may be some questions from that, because I can talk a little bit about other services carrying on with diagnostics and outpatients. Importantly, encouraging people and patients to make sure they keep their appointments, many appointments done by video or telephone link. The support we provide to staff has been really important, including additional psychological support to help staff, particularly those in the acute medical areas and intensive care areas where they've had to deal with a lot of very ill patients, and unfortunately death, and the difficulty that has been for families not being able to visit and be in the hospital for the patient's illness. So I'll leave it there really, and take any questions if anybody has any, if that's okay. Let me just stop sharing. There you go.
Yeah, have you got any questions? Councillor Carmichael?
Yeah, my only question was around, I couldn't quite see the slide, so I just wanted to know how big the peak was after Christmas, if the Christmas break that we all enjoyed caused a lot of hassle in our hospitals here.
Yes, the peak was about the 16th of January, so it is certainly possible that transmission within families at that time may have contributed to that rise, but obviously there are lots of other things going on at the same time as well. The new variants, because the peaks were slightly earlier in London and the southeast, weren't they? So I think there's a whole combination of factors, but I mean, I think that's why it's important to stick with social distancing as much as possible, and hopefully we'll get the vaccination into those vulnerable groups as quickly as possible.
Thank you, David.
Sorry you couldn't see the slides.
Any more questions? No, all I want to say is thank you, David, for all the hard work all your team is putting in, and we just can't thank you enough.
Okay, thanks Elaine. As I say, it has been remarkable work and resilience. It makes you very sort of humble and proud when you go and talk to the staff about what they're dealing with. So thank you for that, it's appreciated.
Okay, thank you. Okay, now we go on to the next item, vaccination update. Is that Neil who's giving that?
Chair, you've just had the vaccination update.
That's
moving
thank
on
you.
to
I thought,
item
well,
7.
I don't know whether Neil's got anything he wants to bring in.
No, I mean, I suppose it's a good opportunity for me to thank all the staff for their hard work. I mean, we try and do that continually, but it has been a massive joint effort right across the partnership, has been described for you tonight. As you can imagine, it's quite nice to sort of sit back and sort of look at how things have worked, but at times there's been high pressure, high demand and high stress, and people have worked incredibly long hours and worked incredibly hard to keep all that ticking over. So just like yourselves, you know, I want to thank the staff for all their work, and they've really driven this and coordinated it and got us to the place where we are.
Okay, thanks Neil. Yeah, we really do appreciate them. Okay, we'll go on to item 7, the winter grants programme.
Okay, good evening everyone. Let me see if I can try and share my slides with you. Can everyone see the slides?
Yes, Karen.
Yes.
It's okay.
Yes.
Now I've got the slides up. I can't see anyone else, so someone will just have to shout if there's some questions. Okay, what I was planning to do tonight was a follow-up from a couple of months ago when I came and spoke to you all about the original guidance around the winter grant and our thoughts on the approach and the operating model in terms of how we take it forward. So just thought I'd do a little bit of a recap on that and then kind of explain where we're up to here and now. So we all know that the COVID winter grant scheme we had guidance issued out in November, and it was about us thinking about how we could provide additional support to our vulnerable households with families and households without children It was also to look at households that had been directly affected by the pandemic and how we could provide this support from the 1st of December through to the 31st of March. We know that the grant value was 170 million, and we know from Sandwell's perspective that equated to just slightly approximately over the 1.4 million. And as I've said, this was about a funding grant that was to run from the 1st of December through to the 31st of March. There were some really specific conditions in how we spent this money. So there were a real clear indication that 80% of the grant after administration costs should be ring-fenced to vulnerable households with children, and that 20% of the grant after administration costs should go to vulnerable households without children. It was in line with how we could start to think about our targeted groups, and that there were suggestions that we used Searchlight portal that wasn't just looking at families with welfare benefits, but also looking at families that may have been on low incomes as an example. The guidance was really clear that it wasn't to cover rent payments or housing costs or any general advice around management and debt, and it was around how we supported people predominantly with food and fuel concerns. How can it be spent? As I said, 80% of the total funding was to be provided with food and energy and water bill type associated costs, and that there was also a caveat within the guidance that we could support 20% of the funding with costs related to food and fuel. So the scheme talked about things like sanitary products, cleaning, warm clothing, blankets, boiler repair, etc., as well as elements of equipment that were linked back into heating and food, for instance, fridges, freezers, ovens and microwaves. We developed an operating model in 4 steps. So we talked about how we would pick up requests from the residents of Sandwell, how we would have that warm conversation with that applicant and understand the needs and the outcomes of the household, how we would determine the validation of payment and the types of payments that we would offer. So we had agreed that we would do a voucher scheme for anything to do with food, warm clothing, essentials, and that we would use PayPoint in terms of anything to do with boiler repairs and support with fuel. We then had the 4th stage of the payment was to make sure that 1, those payments went to those applications, and that we would do a follow-up call to make sure that everything was okay. When we looked at the allocation of funds for Sandwell, around the 1.4 million, and we looked at the offer in relation to an average family, we based our predicted positioning at the end of 31st of January is about receiving around just approximately 4,000 applications. We also looked at in terms of the approval of those funds and the award that we should be spending at the 31st of January based on the 1.4 million allocation. And this was a predicted position around about £175 per household. What we seen when we got to 31st of January was a huge amount of applications. So the predicted 4,000 in reality became 5,766 approximately. And by the time we got to the 31st of January, we'd approved over 3,200 applications, and that we'd awarded over £500,000 in funds. And that the average ward, which we had predicted of around about 175 at that moment in time, was around 158. But as you appreciate, every single day, that data is changing, the figures are changing, the amount we award is changing. And so what I've tried to show today on the slides is the position that we were at the 31st of January. But as I said, every minute, every hour, the status changes. From the feedback so far, within the policy, we built in a complaints and an appeals process. And at the 31st of January, we had no formal complaints or formal appeals in the operating model. But what I've tried to do today is to share some of the formal compliments that we've had, some of the feedback that we've received from the residents of Sandwell in relation to the work that the team have been doing, which I think that you will see has been a really positive feedback. So some of these are from children, their parents have shared what their children have said, and others are from the applicants themselves. So have we got any questions on the winter grant before I progress to the clinically extremely vulnerable update?
Councillor Jones?
Yeah, sorry,
I haven't got my mic on.
I lip read that. Sorry. So just firstly, can we get a demographic of the breakdown into wards at some point about how many within our wards have applied for grants, so that we can sort of see the spread across Sandwell? I noticed that there are 2,489 people who applied but were not successful. I wondered, at what point do you walk them through the process? Do they have to make an application first before you then go through that 4-stage process with them to identify their needs? So do they first step up and say, I need some help, and then you say, well, actually these are the rules, or is it these are the rules? We've got 2,489 people who haven't appealed, or there's no complaints against that as well. Is that because it's at the start of the process they make the application, you then sort of explain to them why they're not successful, and that's why there's no sort of appeals moving forward as well? But I do think 2,489, obviously it was oversubscribed, but it's quite a lot of people who have applied but then have been disappointed in the outcome. And sort of just having a look at why people felt that they needed to apply, and whether the grant criteria is a bit too stringent, maybe. I don't know.
Okay, thank you, Councillor Jones. In terms of the responses back to the questions, the figures are showing those applications that we're still considering and those applications that have been approved. So at this moment in time, we predicted around 65 applications a day. We're getting on average 145, 150 a day. We're processing at the moment around about 750 applications a week. So at the beginning of the process, we started with a small team of around 8 or 9 officers supporting. We've increased that team now every week based on the figures, up to around 30 staff that are being redeployed and supporting us with it. So what we've got at the moment is we've got 3,500 people that have had their applications approved and have had their monies awarded, and we are working through the other 2,000 applications. So it's not that those applications have been rejected, it's the fact that they're still within their journey of that 4-stage process.
Thank you. That makes it a lot clearer. It is still quite worrying that we're oversubscribed for this grant, and no sort of judgment on your part. I think it's just a general worry that there is this many people within Sandwell that are asking for help, and I think we need to be as accommodating as possible at the moment for that. But thank you for all the work you're doing as well.
Okay, thank you. In relation to, sorry, Chair, in relation to the breakdown, at the moment we've got all the data per town, but I will take that back tonight and ask the data analysis to break down the data so far in relation to ward level.
Thank you. Sorry, Elaine, per town's great as well, but thank you very much. Thank
okay,
you.
I can, yeah, we can.
Could I also ask roughly how long are the claims taking?
On the website at the moment, we've said that application forms take between 7 and 10 working days. And as I said, the high demand of applications, we're working through that. So we're constantly reviewing the capacity versus demand. And we are, as I said, building up that team in order to do that. in relation to here and now, I can't give you the exact timeline, but as I said, we're constantly reviewing it and updating the staffing levels to be able to deal with the demand. The reason that we predicted the 65 applications per day was on the fact that we were given a predefined amount of money, which was the 1.4 million. We knew that the average household value would be 175, and we knew that we had to run the scheme from the 1st of December through to the 31st of March. So the predictions were based on the predefined amount of money that we were going to be allocated, and that works out to around 7,800 applicants over that 16-week period. What I can say is that the team have worked extremely hard, and we are aiming to process all of those claims as quickly as we can. However, that creates a caveat for us in terms of whether we will have enough funds in the system in order to take us through to the 31st of March.
Okay, thank you. Councillor Carmichael's got a question.
Yes, thank you. You may have answered this, my internet keeps dropping out. What's the maximum amount that can be applied for?
Okay, so the way that we pulled the policy together was based on circumstance. So that's why we have that conversation with that applicant first. So depending on their circumstances and depending on the composition of their family unit, it will be dependent. So if we have got a single person or a single adult living in a household, the value that they will get will be totally different to a couple with 3 children or 5 children or 6 children. We've got some people presenting that are only struggling for food, and we've got some people presenting that may be struggling for food but also may be struggling with boiler repair. So depending on the person's personal circumstances will be the award they got. We clearly defined our offer in the policy right at the very beginning, and our officers take each applicant through a conversation.
So sorry, so you've got a set amount for each criteria within the application. So if somebody's applying for food, for instance, there's a certain maximum threshold. Is that what I understand that they can have?
That's right. So if we take food as an example, if you're a couple, the amount of money that you get awarded for food is £40, and for every child it's £15 for every child that you have. So if there's just a couple, obviously it's £40. If you're a couple with 2 children, it then becomes £70.
Right. Okay, I understand now. Thank you. Thank you.
Is that? I've got another question. Will we get any more funding, or is this just? I know that's an answer you can't really, a question you can't really answer.
My understanding is the winter grant is a one-off grant that was predefined and it lasts for a period of time. I did explore whether there was going to be something called a spring grant, but we've had no feedback on that. So I can only assume the winter grant is here. It's a defined amount of money for a defined amount of time.
Okay, thank you. Anybody else got any more questions? No? Can you thank your team for all the hard work they're doing?
Okay, thank you.
Because we couldn't do without you neither, because there's a lot of people out there who are really struggling. Thank you.
Would you like me to give an update on the clinically extremely vulnerable?
Please.
Okay, let me see if I can share my...
Before you do that, can I introduce someone? I should have done it earlier on. I was just engrossed in the meeting. Our new director, Catherine.
Hello, hi.
Hello.
Yes, I'm Catherine Wilmette. I'm the new interim director of adult social care. Nice to meet you all.
Nice to meet you. Thank you. Okay, Karen, you can carry on now.
Okay, let me see if I can try and share. Okay, can everyone see the presentation?
I can see it.
Okay, so
yeah.
The other thing that we've been working on is relating to the clinically extremely vulnerable. So the guidance for clinically extremely vulnerable came out right at the beginning, March last year, around the ask of the local authorities in terms of supporting people that have been deemed to be clinically extremely vulnerable to COVID-19. Local authorities were provided with a revised guidance on the shielding and the protecting of people who were clinically extremely vulnerable, and that was updated on the 22nd of January 2021. So that looked at the support for us whilst we were in our tiering system, and also in December when we went into the level 5 levels. We know in Sandwell that we have on average 13,000 residents who have been identified as clinically extremely vulnerable. We are provided with an up-to-date list of all clinically extremely vulnerable on a weekly basis. So we're keeping the information up to date, and we're constantly reviewing that information. The 13,000 residents are made up of children, so we've got 262 children that are clinically extremely vulnerable up to the age of 18, and that we've got over just 12,500 adults 18 and above. The ask of us this time round is that councils should directly contact clinically extremely individuals who present locally to register through the national shielding system. So this is our reactive pathway. So the National Registered Shielding System allows all of our residents to go onto the NHS England website, and it allows them through the system to request support of us as a council. We get that information on a daily basis. So some days we may have 5 or 6 people requesting support, on other days we may have 20. Until we come to work first thing in the morning, we don't actually know who's registered on the system the day before. And we've got a team of staff that have been redeployed across the council to support us to work with those individuals. We know that the council should be ready to contact all clinically extremely individuals, and it's around about the support that we can provide. Now the guidance, the recent guidance hasn't changed that offer. So there's 2 elements. It's looking at support in order to give people access to food, or support for people with basic support needs. So for instance, we know that clinically extremely vulnerable are being advised to stay at home. So their access to support around food sometimes can be really limited. And we also know from past experience that when we've got clinically extremely vulnerable that may already have care needs, their relatives may not be able to visit them, and they may have been relying on family and friends to support. So again, it's given us the opportunity to reach out to those people we wouldn't necessarily have known. The third ask for us this time round was that the council should be ready proactively to contact all those that have been recently added to the shielding patient list. So that wasn't to go back and contact every single person on the 13,000. That was for us to go back and contact those that have been added to the shielding list from the October database. So again, offer remains the same, access to food, and there was 3 elements to the access to food. There was the ability for us to support our clinically extremely vulnerable to have access to priority supermarket slots, how we tapped people into the voluntary organisations in terms of befriending and support for people to do their shopping on their behalf, and under extreme circumstances to be able to deliver food parcels to those clinically extremely vulnerable people. The second ask, as I said, was around basic support needs, and there were 2 elements. One, how we supported people to link into the voluntary organisations, especially for people that were suffering from isolation, mental health, etc. And also to bring people into adult social care and into social care if they were struggling and required more formal intervention. We have to do returns to the government based on the clinically extremely vulnerable, and we have to do returns every 2 weeks. So what I wanted to share with you today was the last return that we submitted. So between the 22nd of January and the 4th of February, the council had contacted 1,118 people, which was part of the ask. So it was clinically extremely vulnerable people that had been added to the list, and it was also people that we knew that we physically supported in the last round in the last phase. At this moment in the time, the council was unable to contact the 48. So what we're doing around those 48 is we're actually looking at deploying some face-to-face visits as well. So this isn't just about a desktop telephone support network. This is also about us using our floating support staff, and we're actually going out and doing face-to-face visits on those 48 individuals. In terms of actual support, we've supported 75 people to access food, 61 people to access the priority supermarket slots, and we've provided 16 people with basic care needs. I think what it does show is that we have provided and reacted really well in the first phase, and that a lot of our clinically extremely vulnerable residents are still continuing to use all of the support and all of the strategies from the first phase. So the number of people that have actually needed support from us this time is significantly lower to last time. And what we were hearing from the residents of Sandwell is that they've continued to retain the support that they had from the voluntary sector the first time round. Slides over. Any questions?
Any questions? Councillor Jones.
Sorry, I'm always first in there, aren't I? So I just wonder whether there is any limit to our support that we give our residents. For instance, I've had a resident contact me this week who inquired about a food parcel, but was told that you've had 3 already. You're not entitled to another food parcel. However, he's clinically extremely vulnerable, doesn't have a visa card, isn't able to get out of his home, and I just wondered whether we are putting those limits on, or whether he's just misunderstood.
What they asked was, Councillor Jones, is the food parcel is an emergency food parcel, and what we would be hoping to do is to work with the resident of Sandwell over that period of time to then link that person into the voluntary organisation. So the food parcel offer that's part of this guidance is for an emergency situation only. It's not to replicate what we've seen from a national programme in March, where people on the clinically extremely vulnerable were getting weekly packages through the NHS programme. So there is no limit on the number of emergency food parcels people require. But what I would stress that it is an emergency, and we should be working with that individual to look at alternatives.
Thank you. I probably will pass this individual on to you, Karen. I've inquired elsewhere. However, his circumstances are that he only does his banking at the bank. He's not been able to get to the bank since March. He only uses a bank card. The help that was offered to him was that they were going to take his bank card and draw money out on his behalf, and then use that as money. But he was really, and I think I would be uncomfortable giving someone my bank card. Not that I've got that much in the bank, but I think I think he was just a bit concerned, so I will pass him on to you, Karen, if that's okay.
That would be fine, no problems.
Thank you, though. But again, it is wonderful what you're doing, so carry on.
Councillor Carmichael.
Yeah, thank you. Mine's just a quick question, really. You know, of all the severely vulnerable you've got, can they actually opt out of receiving phone calls? I mean, that would ease pressure on the council, obviously, if there was many. I mean, I actually receive phone calls, and there's no need for me to receive a phone call. So just wondering if that question could be asked when that phone call's been made.
Yeah, so we can definitely take that on board. So there is an ability for us to record when we make contact if people no longer want any follow-up calls, and we can record that in the system, and we should then take note of that request. So I will take that back, Councillor Carmichael, because that is a really useful statement, because I do think this time round we're now, I think, on the fourth round of ringing clinically extremely vulnerable people, so we do have that facility to do that. So I'll double check the guidance that we give to the volunteers that are supporting us with that programme and take that comment on board.
Okay, thank you.
I've got a question. Who tells you when they're clinically vulnerable? Is it the doctors or the staff?
At the moment, we get the database from Central NHS England, and there is a number of ways in which a person can be on the clinically extremely vulnerable list or be taken off. So my understanding is that's based on a set of criteria, and that criteria and that data is pulled out of information from the GPs, information from medical consultants, etc., etc.
And is it the doctors who have to put them on the list, or the consultants?
Both. So I think that both, all various types of medics can put people on the list. And as I said, we have had situations where people have asked to be taken off the list.
It's all right. There's one or two I know who I would class as clinically vulnerable, and they have never been put on the list.
Okay. I would suggest that they go back and have that conversation with their GPs.
Okay. All right. Okay. Thank you. Anybody else got any questions? No. Thank you again. Thank you for giving us a report, and thank all your staff for us again. Thank you.
Thank you.
That's the last item. Deb, have we got a date for the next meeting yet?
Yes, Chair, the next meeting on the 29th of March.
Thank you. Okay, next meeting is March the 29th. I'll just say thank you for everybody for attending, all the reports we've had, and thank Catherine for coming. I don't know whether anyone wants to say anything before we close. Catherine, would you like to say anything before we close?
Sorry, I was on mute. Just to say, I'm really pleased to be here, and it's been really informative for me to hear about all of the work that's been on, and there's clearly been some fantastic work happening. So I hope I can continue to add to that in the next few months that I'm here. Thank you. Thanks for inviting me.
Okay, thank you for turning up. Okay, I'll close the meeting then and say thank you all for coming, and I'll see you on the 29th of March.
Thank you.
Okay,
Thanks,
bye.
Deb. Bye-bye.
Thank you.
Thank you all. Take care.
Bye.
Bye.